Hello again and welcome. Last episode, we heard from Jennifer Higgins, a chief nursing officer, as she discussed with Susan Minaya about the professional practice model. Moving on, this episode will continue the conversation on workforce development in healthcare as Susan Minaya speaks with Susan Davis, a resuscitation education manager, regarding clinical competency training in healthcare. Stay tuned to learn more.
This week, what we want to talk about is really clinical competency training in healthcare. With me today is Susan Davis, who is a nurse, and she also is an entrepreneur. So welcome, Susan. How are you doing today?
Wonderful, Susan. Thank you so much for having me. It's a great topic, and I look forward to digging into it with you.
Okay, great. Well, I think we'll just get on it, if you will. So, Susan, do you want to share a little bit about yourself, though, before we get started?
Sure. So I am a nurse with a specialty. Back in the day, I started my nursing career as a trauma nurse, and I started as an associate degree nurse. I moved my way up over the years into cardiac, and I got my master's and then eventually my doctorate in leadership in nursing. And I actually also have my paramedic license, which seemed to kind of change the direction of my career and led me toward a more cardiac and resuscitation education view, lens, if you will, of nursing. So that's kind of where I am today.
Oh, that's great. But I think that breadth will really, you've probably seen a lot of different ways that clinical competency training is done and how it's served up, if you will, throughout different healthcare organizations or university settings. So it'll be fun to hear from you about that. So let's talk about it. So in the healthcare environment, what are some of the challenges that healthcare organizations face in this area of competency training, specifically for clinical staff? And what are the implications if those are not done well?
So it's an interesting thought process. You know, when I first did my very first round of clinical competencies as a bedside nurse, I was a trauma nurse. And it's such a different view when you're a bedside nurse going to your mandatory training. And of course, in trauma, then it was a specialty area. So those competencies were directed specifically toward my specialty area. And that has to be expanded throughout the entire system. There's inpatient, outpatient, many different areas. And it's a large, broad area. And honestly, Susan, the pace of change versus the sheer volume of skills that have to be taught, and not only taught, but assimilated, and then to have it actually be seen at the bedside, seen in practice, seen in our outcomes with our patients, that's a giant challenge.
Yeah, I can imagine, because, you know, I think we see different ways, right, that they do those kind of competencies. And when you talk about challenge, it seems like this has been a common theme throughout all of the different podcasts we've done, is really just the velocity of change, what's expected for people to know, the body of knowledge that they have to incorporate. I think some things don't change, but then, you know, you always have these big surprises, right, like pandemics and things like that really kind of change the way things need to be done, or ratchet them up to a different level than what they were currently being done. Have you seen that?
No, absolutely. I mean, we have our core set of knowledge, and if you're going to be evaluating competence and or confidence in skill sets, we have to go way upstream into that initial set of education. What did that look like? What did it mean to the person learning it then versus now that they're using these skills, you know, in real life? School, you know, education has to be meaningful for it to really set in. And then they have to be able to practice in order for those skills to come to fruition, you know, if you will, and for our patients to feel safe, for the practitioner, the nurse to feel safe. So it has to be a continuous learning environment. We all have to be flexible. Yeah, go ahead and throw in a pandemic, and then what happens? You know, the learning modality changes. The volume hasn't changed. It's only increased in what we need to assimilate and be able to use skillfully. And then how do we deliver that care? I mean, pre-pandemic, our education, I should say, and care. Pre-pandemic, it was kind of, you know, becoming, you know, a little cool to have a digital course here and there, and education was moving to the online setting for some time. But now here we are, pandemic, pre-pandemic, post-pandemic. Is that education the best? I mean, do people still crave the face-to-face environment? Is completely digital going to work? Is it blended that we're after? And ultimately, are we seeing what we need to see at the bedside? Are we seeing the care to our patients and to our community that we need.
Yes, and I think I completely agree with what you're talking about, but that blended approach is probably closer to the right answer, right? Because even if you do scenario based, I think there's still room for things like virtual competency assessment, but then coupled with demonstration, right? Because when you actually take the circumstance of the human connection with the patient, I think it's interesting to see how the knowledge translates into the action.
Susan, for instance, my specialty area, resuscitation education, there forever, the American Heart Association has had the face-to-face environment was the gold standard. And then over the years, they came to blended. So you would take the online didactic portion and you would still have to go to meet an instructor and do your skills. That's great. And now the best evidence today available is this completely online course, and then a self-directed, the skills are done in a self-directed computerized station. So, for me, I oversaw a very large American Heart Association program for a local healthcare system, and did hundreds and hundreds of practitioners each week. And ultimately, regardless whether it was 100% face-to-face, blended, and or completely on the computer, the bottom line is it's still not enough. We are not seeing the resuscitation expertise that we should be seeing in a cardiac arrest in the in-hospital environment. We're just not seeing it. So at some point, if the best evidence says that we should be doing this brief, frequent, hands-on training, yet today, the recommended education is every 2 years, in a classroom in the land far, far away from where we actually use these skills with equipment that we don't actually use. At some point, when someone's having a cardiac arrest, your hands are going to be on a patient, and it becomes very real. So you have these many things that nurses have to remain competent in, are high risk and low frequency. And ultimately, if they're not skilled, it truly is the difference between life or death. So what we're doing now is just not enough.
I think ways to streamline it, right? Because if you think about it, how when you look at the setting for competency assessments, a lot of times they are like through competency assessment fairs or something like that, where people kind of do the circuit of the different competency areas. And then I've also seen where there's where you have like online assessments that kind of connect knowledge, but as I was mentioning, using the scenario based to say, I understand fundamentally what I need to do and how to do it, and I can articulate the actions that I need to take. And I do think that the seeing it, which I think you're talking about, I think the best case is there, but it's so laborious, that's the big challenge, but yet the healthcare organizations are really, they have to demonstrate that they have those competencies, right? So it's like a regulatory requirement for them, correct?
Yes, very much so, correct. But laborious, you hit the nail on the head there. I think like healthcare organizations right now are very much trying to really listen. What are their staff asking for? And it is a blend. There's certain generations that want everything online they can possibly get, and in fact, they want less is more. And so educators are scrambling to figure out, how do we give less but more? No one wants education, frankly, to be more than a minute. So if you're going to bring everybody face to face, hundreds of them through, how is that validated? I can say relationship building is there, eye-to-eye contact is there, the relationship building is there. That's fabulous, but how is it validated? Are we still going to see what we need to see at the bedside for this huge volume of skills that, again, the regulatory those are the core. But what about everything new? There's so many new things. There's new things because of a problem in the environment we have to train. There's new equipment that comes out, oh my goodness, every 10 minutes. So the training is so continuous. And to your point, the teams that are required to assess that need are also huge. And they have to be specialists. You can't just be a nursing educator anymore. You have to be a nursing professional development specialist. I'm blessed to work with them. I'll tell you, I just was in a meeting yesterday with a local team member and some colleagues that invited me to speak about my specialty, and because they're wanting to bring in Code Prep, a program that I developed years ago based on the same conversation. How do we bridge this education piece with what we're seeing clinically. And I was so impressed. They were all nursing professional development specialists, and they spent an entire day brainstorming on and evaluating how their competencies just went. How did they feel? What they were effective, and moving forward, they were already planning on how to do better. And they were reassessing for the next round, which actually wasn't going to be their yearly competencies. It was, what is the here and now need? And in fact, code blue practice was identified as a major need, and they want to start now.
Yeah. And, and we talk about that. I think you're starting to dip into the next thing that I wanted to chat with you about, was really some of the best practices that you've seen in healthcare organizations to really identify gaps potentially that need to be addressed, and then monitoring them to be able to ensure that the staff is ready, right? So it's like you said, no one really wants to take the time to be trained, but you've always have this tension between regulatory bodies saying you must demonstrate the competency on the pressure of the bedside nurses and other people in healthcare organizations that have to take care of the patients, and then where do we carve out that time to be able to actually get skilled up or validate those skills? So what are some of the best practices that you've seen throughout your career?
Well, Susan, there's lots of debate out there on whether the top-down approach or the bottom-up approach, which one's going to work the best. And I think right now the best practices that I'm seeing is really meeting in the middle. The top-down approaches, there's always a business angle that I don't think people from the bottom up consider as much as they should. I really wish nurses had more, even just business 101 training, because some of these decisions on how we're going to be educated, when we're going to be educated, the amount of resources that are allocated to that education, we should understand them a little bit better as a nursing workforce in general, from a business standpoint. For sure. I mean, we don't have any training in that area, but quite frequently, when we get a no instead of go, it's financial. And when you're in the field and you're at the bedside, you're not feeling, you don't understand that it's a financial push from behind. You just know what you need. So I think best practice today is having that elevated professional view and ear from the bedside, clinical nurse leaders that are listening and speak the same language as the executive leadership, and somehow coming together on the business model that works for the functionality at the bedside. But at the same time, identifying knowledge gaps is something that we have to do self as a nurse. You have to find your own gaps in knowledge and be willing to remediate and take accountability for that education and have a voice. You have to be humble enough to say, I don't know what I don't know, and I don't feel safe. Please help me. This is what I want to learn. We can't just leave it to the top or the nursing educators that aren't working at the bedside to decide that line of inquiry. We have to take responsibility. And I think nurses as a whole, we make those decisions to be lifelong learners and own our knowledge. I wouldn't dare, whatever area or environment that I was in, would go in without knowing the best evidence of what it is I was meant to speak about. I just wouldn't dare. And I don't think most nurses would. And ultimately, those decisions on whether we are confident in our own knowledge and confidence at the bedside is our healthcare. That is healthcare. We're 3.5 million people in this country, nurses. Susan? I think it's like almost 300 million in the world. That's a lot of people taking care of your family.
With varying degrees of competency, but yes. I love that about really having to own some of that, so not necessarily having the development piece being done to you, but it's taking ownership for that. And I really like that. And I've seen some really great examples of governance and committees within healthcare organizations really kind of help bring that voice, maybe like the global need, and also kind of helping support the education teams to really understand what's needed with the group, because they're getting the voice of the bedside nurses, to your point, saying, here's things where I don't feel comfortable, and being able to use that as a filtering tool. And I think that that's really powerful, because it's not a lot of disparate voices. There's a way to get that information up and then distilled down to say, where's the greatest level of need that we can kind of solve for together as an organization. Have you seen that as well?
No, for certain. I mean, I know the organization that I work for, we have a clinical education council, and everyone that's on the council, that's open to bedside nurses. All of these councils are open to anybody who wants to participate. So we have clinical education councils, we have clinical practice councils, we have quality and safety councils. Where I'm working now, we are now creating smaller individual code blue councils so that we really can get granular on our data. I mean, literally down to each defibrillator and each compression, we can look to analyze and bring back to our teams once we start our more frequent hands-on practice. But yes, and then there's so much education involved. The difference again between being an educator in clinical learning, or the person that goes that extra mile, and the organization that supports them becoming nursing professional development specialists. That's a big deal. So there's a lot of ways. One of the amazing things about nursing is there's always movement up, and there's support for that. So no matter what your position is as the nurse, bedside, there's clinical nurse ladders, there's councils, there's professional councils you can join. There's a million ways to have your voice heard, and together collaboratively come up with these decisions on what is the best method and content that we need to be training our teams, today.
Right. Yeah, it's, I think the infrastructures are probably there in most healthcare organizations for leveraging, and for whatever reason, it's really a great way to do it. And when we were talking with Jennifer Higgins last week about the professional practice model, how that was really it was a collaborative, right, between the nursing staff and executive leadership, and it was really a powerful experience. And so it's kind of like we do our best work when we work together.
I agree, and that practice model honestly makes me stand taller as a nurse. I mean, that whole initiative is something to be extremely proud of. Every nurse should be so proud to be part of that, and to have leadership that decided to really invest and go that direction. To me, it's really leveling up. And I think in today's day and age, from an entrepreneur's perspective, from a nurse and now a nurse leader, leveling up is just the only way to go.
Yeah, that's great. Well, let's kind of wrap up. I want to talk a little bit, because I know really your passion beyond a doubt is resuscitation, right? And being able to be prepared. And so you, as an entrepreneur, have created your own curriculum of code prep, which you have. But just talk to me about what are your observations across healthcare organizations in general, this gap with this capability set, and what you think it takes to really help them get up to speed with that.
So, Susan, this has become a crazy passion of mine. And it's one of those things that, path I never knew I was going to have or be on, or how it happened, who knows. But I noticed years ago working in trauma, when we would respond to a code blue in the inpatient environment, it always amazed me, the kind of chaotic scene, which I know nurses around the world would agree with me. Those first few minutes of cardiac arrest, I mean, let's face it, it's scary. It's definitely a low frequency, high risk event. It doesn't happen very often, outside of the ER and ICU, and we kind of fall apart. And when I really started looking into that training, I thought, well, what are we doing to support these team members, to empower them, to give them the confidence to do exactly what they need to do in those first couple minutes before help arrives? And it really wasn't there. It wasn't there. The only training is most healthcare systems. It's the minimal, which is the American Heart Association or Red Cross or whichever they choose, which is again once in a classroom in the land far, far away every 2 years. So I dug in a lot on this and discovered, I studied what healthcare systems were doing all over the world is to remedy this. I mean, even the American Heart for years have said that what we're doing is not enough. That brief, repetitive, hands-on practice in their environment with their equipment and their teams is where we need to be. And so that's what I created. And also, I realized that with this less is more, because nobody reads anything, my program, Code Prep, is really the meat and potatoes of recognizing the problem, calling for help, beginning high-quality compressions, using your emergency equipment as soon as possible. So I can see, let's go back to competencies for just a second. The crash cart itself tends to fall into the yearly competency list. And, they do scavenger hunt and they'll go through the drawers. And then, they go back to their unit and the defibrillator sits on top. And there's a lot of fear around that piece of equipment. Once a year in competencies is really not enough to feel comfortable with your emergency equipment. So that's just, it just got under my skin, and it became my, this is the soapbox that, if you let me talk about it, I'll drive everybody crazy, because we just need to get in there and do it. And so that's what code prep is. It's unit-based resuscitation drills, and the primary focus is for nurse and other healthcare professionals' self-efficacy, specifically resuscitation self-efficacy.
Yeah. And I think too, you have a component of that that's really about kind of making them be competent and keeping it alive, sustainable, right? So it's not just a once a year kind of thing. So it's more, right, from a more coaching perspective. So you build that competency within the organization.
Yes, no, absolutely. It's continuous quality improvement. It's ongoing. Once you start, cardiac arrests, Susan, are not going to go away. So neither should be anything.
No.
If you have a heart, you qualify. Mock codes are something that a lot of critical care departments end up doing. And I studied mock codes. Honestly, my opinion of mock codes are that they're not generally standardized. They tend to be infrequent. Do they work? Yes. Anything anyone's doing in this area makes me happy, because it's more than the, just the absolute minimal. But brief, hands-on, continuous practice. This is based on 2 to 6 minute drills. Some of this training comes from my paramedic experience. Let's face it, who sees more cardiac arrests than them? Nobody. So, we do kind of pit crew style, brief, repetitive practice, and it's ongoing. My recommendation is about every 6 weeks. And that usually makes leaders ruffle their feathers, because they don't want to overwhelm their teams. But I really then end up, really emphasizing 2 to 6 minutes, guys. That's all I need. Brief, repetitive, hands-on practice.
That's awesome. It's so fun to hear you talk about that. And I know you just have such a breadth of experience as a nurse over these many years that you've been doing it. And also as you continue to walk the talk with your own continuous learning, and never being a lifelong learner, and continuing like with your doctorate, which has also led to you to actually create this, one of the most, I think, significant competency areas in a healthcare organization. So I want to wish you all the best with your new program and products that you have coming up, I think, in the fall part of this year. And I would just like to say, keep going, and thank you so much for your care and concern in that area, because it takes people with that kind of passion to really get the attention that you need, I think, to be able to reconcile the competencies and really do the things that are needful for the outcome, the best patient care outcome, right?
Susan, absolutely. And I'll tell you, it's code prep is so much fun. I've literally been, I call it code prepping in dark alleys, for years now, because, different hospitals and different units and passionate managers, or anybody in a hospital that really feel that gap, that those first 2 to 6 minutes of cardiac arrest, they would just call me, and for years, I have just gone and trained their units. When you look at them, Susan, after we do it in 2 to 6 minutes, they stand taller. It's just such an easy process. And when you watch them, they laugh, they have fun, and they ultimately have the skill. So that's what's driving my passion. I just, what we're doing is not enough. So I am so excited to open this to the world. Yes, my goal is in October, it will be opening to anyone in healthcare who wants to get in, units, individual people, whole healthcare systems. It's going to be so cool and so much fun watching these people become resuscitation experts. High performing resuscitation systems is my goal. So starting with the nurse.
Yeah, that's awesome. Susan, I wish you all the best and every success. And just thank you so much for making time to talk with me today.
I cannot thank you enough for having me. Thank you so much.
Okay, take care.
Thank you. Bye-bye.
Well, again, thank you both for your discussion on clinical competency training in healthcare. This wraps up our 5-minute university series on workforce development in healthcare. Be sure to stay tuned for our next 5-minute university topic and discussion. Thank you for listening in, and we hope you gain some insights. Until next time.